Hi everybody. I am just reaching out with these videos on assessment and treatment. I wanted to make sure you had these just in case you wanted to kind of look through the learning objectives that are associated with this content. We just had not had a chance to really get to these in class. When we come together on the 22nd after our two guest lectures that are on pretty substantial topics, both the ear and neuroanatomy, we're going to try and take some of the most recent learning objectives, both from assessment and treatment, in relationship to neuroanatomy, in relationship to the ear, and like unpack them a little bit more, which is why I'd like you to have a peek at this prior to our 922 class so that you can be prepared. I am not planning to go through every slide separate from this video. Instead, I'd like to kind of zero in on the learning objectives when we're together next week. So without further ado, I'm actually going to play this for you. This is a video, and I'm going to stop it at various points when necessary.
Talk about assessment and treatment of communication disorders. And so I'm just going to introduce you to some terminology that you may not be familiar with. So if it comes up across the next few weeks, you are familiar with it. This is just an introduction. But as you know, we're interested in how communication disorders and related disorders are addressed in this class. And the way that they're primarily addressed, at least by the professions that we are talking about, is by assessment and treatment. And so let's explore what those processes are. So one term that is integral to the assessment and treatment processes in any healthcare profession is evidence-based practice, which is simply clinical decision-making that relies on three different things, right? Three sides of the triangle. So the clinical expertise of the practitioner, the research evidence that exists out there, studies that have been done that prove the effectiveness of the assessment and treatment processes that are potentially being undertaken, and then the perspectives of the patient. This side with the perspective of the patient also includes any data that you might collect about the patient, that it gives you information about their baseline abilities or performance on different types of communication or related tasks. Okay, so in evidence-based practice, we are using that to inform assessment and treatment that we do. There's also prevention. So speech-language pathologists and audiologists, it's part of their scope of practice to engage in practices that eliminate or work towards eliminating causes of communication disorders, and those practices that also foster optimal communication. For example, I know that teachers are at a greater risk for voice disorders, voice problems where they become hoarse and miss days of school because they're unable to teach because of their voice. They're at much greater risk for voice problems just because of the nature of their job, that they're using their voice a lot. And so one of the ways that I know that may be preventative of a voice problem in a teacher is for them to use the amplification or microphone in the classroom. And so that would be one way for me as a speech-language pathologist to facilitate prevention of voice problems. Another consideration here is just early identification of conditions. So we really want to identify persons as early as we can, if we diagnose them properly with communication impairment or disorder, and then treat it in a timely fashion. If we let it go on for many years and it's unaddressed, it can be harder to treat, and there can be learned habits or compensatory strategies that can be harder to alter and change because they become well practiced, because they've been used for a longer period of time. So early identification and intervention are really, in a way, preventative as well. Okay, so assessment. Assessment of communication disorders is really a systematic process.
Okay, so a question for you. Just as you are listening to this, any thoughts on whether early identification may prevent the perpetuation of speech, language, and hearing problems? This is absolutely true. If we can identify someone earlier, then we may prevent the difficulty from progressing or getting worse, or there being the development of compensatory strategies that are actually maladaptive and not helpful. So hopefully that makes sense to you. All right, let's keep going.
usually from multiple sources, various means, in different settings. That's best practice. And we do this in order to verify and specify communication strengths and weaknesses, identify possible causes of the communication problem, and then make plans to address them. Typically, when we get all of these different facets of assessment, identifying, determining the cause, and making plans to address the impairment, that's going to be addressed through a more formal assessment process. But screening is kind of the first step. So the purpose of a screening is to determine whether a problem exists in the first place. So what I mean by that is, maybe you've had a hearing screening before. The purpose of the screening is just to see if you can hear a certain group of frequencies or pitches that are presented to you via tones, right? If you are unable to hear those or during the screening, then we start to suspect that maybe you have a hearing problem or hearing loss, right? And so that's an example of a screening, but there's not much more that we do during something like a hearing screening. There's other types of screenings, but again, just to give you a reference point. Formal assessment is going to be a much longer process that has many more goals. So we'll talk about some of those other pieces and goals. So, your first order of business in most cases, if you're doing just a screening, is to determine the lack or presence of a problem or an impairment. And sometimes that's not necessary. So, for example, if a patient comes in to the clinic where I work with a voice concern or problem, they've identified already that there's a problem most of the time, and I can usually hear it. Like if they're coming in, I can usually hear that their voice is compromised in some way. So I don't necessarily, need to verify that through screening and can go right to a assessment. But sometimes the screening is important for kind of sorting out whether there is an impairment or problem. If I'm doing a more formal assessment, then I'm really concerned with getting a diagnosis. I want to specify or characterize the impairment or problem in a great deal more detail. I might do some diagnostic therapy where I have the patient do different kinds of communication tests, or if I'm, specifically if I'm talking about something like voice, maybe I want to see if their voice can be improved by certain exercises that we might do, and that gives me an idea of like what might be helpful to them in the future, and maybe the nature of their problem in the first place. Because if I can get some improvement in their voice by them doing certain behavioral exercises, then I know that maybe there's a functional component or, there's a behavioral component to the voice problem versus simply just structure where, something's wrong with the vocal cords or the throat.
So at the end of the day, when we consider assessment, we're really trying to, first maybe determine if there is an impairment in the first place. If we know this, then diagnose what the impairment actually is. Determine if we can do some kind of treatment, sort of, we call it stimulability testing. You don't need to know that word, but just some sort of exercises that may result in improvement. We sometimes call this dynamic assessment, seeing if the individual improves with some teaching or some provided support. And so, again, all features of assessment. We're going to describe strengths, weaknesses, and severity of the condition, and so forth.
If I'm working with a child who isn't very intelligible, it's hard to understand their speech, then I want to know what speech sounds they can produce well and clearly versus ones that they can't. And that gives me an idea of strengths and weaknesses. And then overall severity. If there's lots of sounds that are distorted or unclear, then their speech problem is going to be more severe than if they only have a few that are difficult to understand. A lot of times I'm also tasked with identifying the cause or the etiology of the difficulty or the impairment. So there are typically predisposing, precipitating, and perpetuating causes of impairment. Okay, so when you think of a predisposing factor, what makes people susceptible to the problem? That's your question that you were trying to determine. Precipitating, what makes people begin to have the impairment or show the impairment. Perpetuating, what makes people continue to have the impairment. So sometimes we might ask, like, what makes people susceptible to stuttering, to developing stuttering behavior or disfluencies that are classified as stuttering. Precipitating are what makes a person begin to stutter in the first place. And then perpetuating are what made people continue to stutter across time, or even the severity of their stuttering get worse. So we might be tasked with understanding all those factors, determining a treatment plan, or what that means is what are our goals, what are we actually going to do in treatment to help the patient. It's the prognosis. It's really an informed prediction of the outcome based on all the data we've collected. Do we think the problem will persist if no intervention occurs? How long do we think treatment might last? And how effective do we? And again, what kind of needs does this patient have immediately? That also is going to determine or inform our treatment plan. If the patient is having trouble doing their job because they're having trouble communicating, then that is an example of a functional communication need, right? They are unable to function in their job. So we want to profile this because our treatment is certainly going to be focused on those functional communication needs. During assessment, we tend to take a lot of data, and that data is used to come up with that treatment plan. Okay, so in a nutshell, what we just discussed, all the different tasks that a speech language pathologist or an audiologist is trying to delve into and understand during the assessment process. Okay, some procedures during assessment. So we talked about, like, what are the goals of assessment? What are you actually doing to fulfill those goals? So typically with an assessment, you are going to start with maybe an introduction or an introductory interview where you establish rapport with the patient, explain what you're going to do. So we're going to have you label some pictures in a book here. And after we do that, then I'm going to have you repeat some sentences and things like that. And then ask, well, do you have any questions about what we're about to do? The case history or questionnaire gathers background information. And that's often, that's typically a pretty integral part of any assessment. When you've gone to doctor's offices or other healthcare providers, oftentimes you probably had to fill out an intake form, right? Okay, so here is an example of an intake form from our speech language and hearing clinic on campus here at UW-Madison. It is for children who are coming in for stuttering, who have developed dysfluency or fluency disorder, as we call it, and lots of information about have they received prior services for speech and language problems, what was their medical history, any behavioral concerns, what is their speech fluency like, how they experience stuttering, any history of stuttering in the family, right? So this is a pretty representative kind of case history. We're going to want to systematically observe the client. So most of the time we're interested in how the individual is communicating in as naturalistic a setting as possible. So we want to make our treatment rooms really comfortable and familiar in some ways. Maybe there's toys if we're working with children. We want to, again, observe them in a comfortable environment. A hearing screening is going to be a part of most assessment procedures when we're examining communication, because it's integral, right? So a hearing problem can be a precipitating factor or a causal factor for speech and language problems. If you can't hear, then it's hard to develop accuracy in production of speech, and also if you're not hearing the message, then your language may not develop, right? So hearing screening is also integral. And then we often do an oral facial examination. Some people call that an oral mechanism exam. That simply involves looking in an individual's cavity and seeing how the structures move, like the tongue, lips. Is there full dentition? How do those structures look at baseline, and how do they move and work together with one another? In many cases, I'm going to use a formal test or standardized test. Standardized testing have very specific procedures and scoring methods. There are two major types of standardized tests that we'll talk about. Norm reference, which is when you have the client do a number of tests, take a number of tests, and your scores are then compared to a sample that the test makers derived scores from.
So we've actually talked a little bit about this in terms of difference versus disorder. Remember, whenever you are assessing somebody, it's really important that the population that the test was normed in is representing the client that you're testing. But norm referenced is, again, one of these main types of standardized tests or assessments. And then there's also criterion reference,
so that you can compare your client to the population that was sampled by the test makers. And then there's criterion reference, which are more formal tests where there's standard procedures, but you're describing strengths and weaknesses. There's not going to be a comparison grouping.
Okay, take a moment to just kind of consider, why is a hearing screening an integral part of most assessment procedures? I think you can perhaps identify that it's likely going to be related to how hearing and speech and language might be affecting one another, and so that is the answer here. All right. Okay, so we were talking about criterion reference. Criterion reference might be, you know, oh, my kid can say 50 words. You know, so again, you're dealing with like standards, almost like a checklist sort of thing, versus scoring.
That you're using in your scoring methods. The standard is really the criteria for the task or the skill. So can the child say 10 different words, 10 different color words, for example, right? That's the criteria then, and we're not talking about comparing that to any particular sample population. We might engage in dynamic assessment to probe whether a client is able to modify their behavior. So we use the test, teach, test method. So test them in their ability to do a particular behavior, teach them how to do facets of that behavior that maybe they struggled with, and then test them again and see if there is improvement. Okay, I'm going to show you an example of a standardized assessment, just because I think.
Okay, so dynamic assessment is very similar to diagnostic therapy. It's just, you know, let's see if we can improve the individual's difficulty by testing out certain strategies with them and seeing if by teaching them those strategies, some of their challenges are lessened, right? Okay, so let's look at some standardized assessment here. We're going to look at more AV norm reference assessments, and then we'll look at dynamic assessment.
It can be hard to picture what these actually are without seeing examples of them. So here's a speech pathologist over here, and a child who's being assessed for articulation with an instrument called the Goldman-Christo test of articulation. You don't need to know, the details here, but just kind of look at the process of what the interaction looks like.
Okay, and today I'm going to give him the Goldman-Christo 3 test. It's an articulation test. And we're going to see how he does. I'll ask him a few questions.
Again, a standardized norm reference test. That's norm referenced among a large span of ages of different children to see what speech sounds are accurate and clear across different age children.
Show him some pictures and he'll just tell me what's in the pictures. So let's get started. What is this? My house. Good job. What is this? Good job. What is this? Okay. She is a girl and he is a boy. Good job.
Okay, so then she's marking down whether he is producing each of the speech sounds and the words correctly. And by doing this, you can get a kind of a standard profile of what speech sounds the child can say. You compare that, in this case, to a normative sample that is associated with scoring with this test. Let's look at dynamic assessment.
Now, Mr. Puppet, there's a couple of things I need to tell you about Mr. Puppet. Mr. Puppet, close your ears. Mr. Puppet has a hard time remembering things. And Mr. Puppet likes to talk to children more than adults. So that's why I've invited you to work with Mr. Puppet today. Okay? All right, Mr. Puppet. Yes? I'd like to introduce you to Justin. Hello? Jason. I know. Hello. So, can you help me plan for my picnic? Yeah? Okay. Now, Kate, will you help us first? Okay, I'll help you. All right. Now, I want to take this on my picnic. This is a cookie. Okay, could you put that in the basket? I want to take this up. You want to take this on your picnic? Yes. This, what's that, Kate? Oh, this? It's a towel day. A towel day. A towel day. Could you put that towel day in the picnic basket? Thank you. Now I want to take a cold. Oh, here's your cold. Oh, there, thank you. Could you put the cold in? What is that again? A cold.
See how she's essentially teaching him? Okay, so she's teaching him to see when she again tests him if he is getting these names, if he's learning these word names.
Excellent. And you put that in, and then we're going to put this in and this in. Oh, and my favorite of all, apple. The apple. Okay, good. Put it in. Would you please help me? Would you please give me the cow day? Cow day? Where's the cow day? Where is it? This. Yes. Is that the cow day? Yeah. Mm-hmm. Would you please give me the cookie? The cookie? Yeah. Would you please give me the comb? Yeah. No. There's the comb. Thank you very much. Would you please give me the apple? Thank you. Give me the other two things too.
Okay, so again, kind of looking at how quickly is he able to learn novel words, right? Actually, these are non-words, but again, this will be kind of a form of dynamic assessment. The video goes on, and she does a few more cycles of this. She also has him try to produce the actual objects, not just retrieve them or identify them. So again, we may have some standardized assessment procedures. We may do some other kinds of testing that we'll talk about as we move into discussing other kinds of disorders, like actually instrumental testing to look at things like the voice box and swallowing. But once we've gathered our data, we need to consolidate it and interpret it. And so we probably are going to mention some of the things that we have found to the client and the patient and some preliminary recommendations, and then ask them, hey, what questions do you have in the closing interview? And then we're going to write a report. And so this is an example of a report. Oftentimes we're talking about, what is their case history, what do we find in the evaluation, etc. The report is used in a lot of different ways, but it's going to go back to the client and also contain the treatment plan and be used as kind of a guide moving forward and working with that client or patient.
All right, so we briefly talked about assessment. Let's talk about intervention or treatment. I know that some of these slides and even some of the sounds may be a little shaky. If you're having trouble seeing some of the visuals, remember to look at the PDF, PDF 1.4 that goes with this lecture, so that you can see things a little bit more clearly if you're not able to see them directly on the video. All right, but let's talk about, okay, all right, we've assessed the individual, we have diagnosed them, we've described the impairment, maybe we've done a little bit of dynamic assessment to see what kinds of modalities of treatment might be useful, or we're able to assess sort of what might be especially effective, how the child does with different treatment techniques, and let's describe intervention specifically in a little bit more depth. So we've talked about assessment now. Remember, assessment is all about identifying and characterizing the impairment or problem, whereas intervention, if we just look at a dictionary definition for intervention, it's actions taken to improve a situation or condition. I think we commonly think of this in a medical way, that if there's intervention or treatment for something, that it often comes in the form of a pill, right? But most of the types of treatment that CST professionals provide are going to be behavioral in nature, or they may involve training somebody to use a device that helps them hear better, that allows them to communicate if they're unable to communicate verbally. Those are called AAC devices, or augmentative and alternative communication devices. And you already know this, right? We've had that lecture. But yes, absolutely, there is an assessment to define a good AAC or multiple AAC sort of modalities, right? That's pretty much everything that we talk about in this class. The disorders, in order to be diagnosed, will need to be assessed, and then there's different ways of intervening. Devices, which we'll kind of talk about throughout the semester, depending on the unit we're in. So intervention in the CST professions is primarily behavior in nature. It's important that when we are providing intervention, that we recognize and include considerations of social identity, the age of the client, the environment that they are typically communicating within, their culture. It's very important, and there's been an ever-increasing emphasis in the CST professions to be really culturally responsive and to practice cultural humility, since communication is really shaped by culture. And so really, if we're practicing behavioral interventions or assessing communication, the culture that one comes into the clinic with is going to be really integral to consider. Okay, so we talked about goals of assessment. Let's talk about some goals or objectives of intervention. So
really the overriding objective of treatment or intervention is to improve communication skills when we're talking about CSD interventions. But there's a few other objectives that we're interested in as well. So make sure that you're aware of the term generalization and feel like you can define it. That refers to the idea that when we're working with an individual on communication skills, we don't want them to just be able to use those skills in the treatment room or in the 30 minutes a week that they might be there for therapy, but that their skills generalize or are able to be used in other contexts, settings, and with other communication partners. We also want some level of automaticity. So learning new communication skills is really hard. It takes a lot of attention and focus. But eventually, we hope that those skills become relatively automatic for the individual that is in treatment or intervention. And the idea here is that they're more habitual so that the individual's not having to think about them all the time, because that makes communication more difficult generally and maybe less enjoyable initially. Self-monitoring during that period before certain skills, maybe it's the production of a particular speech sound clearly, is necessary, right? An individual needs to be able to become their own clinician, self-assess whether they're producing.
All right. So intervention should facilitate blank of new communication behavior. I think we know that it is all of these things, right? Automaticity, generalization, right? We want to take skills and use them in multiple contexts or across multiple tasks. I want to be able to pronounce my R's in a word, but if I was working on them in words, eventually I'd hope to be able to produce them clearly in conversation, right? So there's lots of ways you can think about generalization. Could also just be in a setting, in a different setting, right? Therapy room, like we said, versus out in the world. Okay, and then we're talking about automaticity here, so that things become relatively automatic. Let's continue here.
Producing that S sound or that R sound clearly, and then correct if it is distorted or difficult for communication partners to understand. Timeliness. We do want our progress in therapy with a client to occur in the minimum amount of time. So we want the maximum amount of benefit in the minimum amount of time. And then we've talked about this idea of being sensitive to culture. The cultural characteristics of the client need to be considered and embedded within intervention practices and the treatment plan. Okay, so when we're determining actual treatment goals, so we typically make goals for the client or the patient. And in order to do that, certain things that we're going to consider based on what we've already discussed would be some of the needs of the family or the client. Again, oftentimes, if we're working with kids, the family is going to have a great deal of input into the treatment plan, and there's going to be clear needs that the family may have in terms of communicating with their child. For example, maybe Sammy's a 5-year-old who isn't being understood when he talks on the phone with his grandparents. And so maybe a functional goal or want of the family and the client is that they develop some strategies to better communicate with grandma. So maybe those strategies are going to be practiced in a therapeutic or the therapy room context, but the hope is that when the child goes home and goes to speak to grandma on the phone, the strategies are going to be used and generalized, like we just talked about, generalized to use in that actual context, because that's going to make them truly meaningful, the use of those skills in context. Okay. We also don't want to have our goals be so complex and difficult for the client to achieve that they become discouraged. So there should be some ease of ability. It should be kind of like right at that kind of edge for the patient or client where, there's some challenge there, but it's not so challenging that every time they do it, they're actually unable to achieve it. So there's got to be some ability to do the target behavior.
And this, right? It's the same with when you're learning in your classes. There's kind of this zone of proximal development. It's got to be just above that area of challenge. But if there's too much challenge, if there's too much demand, then generally individuals end up being frustrated. If there's not enough demand, then there's no growth, right?
And of course, you want to make sure that the goals that you choose for treatment are age appropriate. I'm not going to work on a speech sound like an R with a 3-year-old child because the R sound doesn't typically become accurate and precise until age 6 and older. And so that wouldn't make sense for me to, it wouldn't really be age appropriate for me to work on the production of an R with a 3-year-old. Okay, so there are many different treatment approaches. You'll learn about some of those behavioral treatment approaches this semester. The type of approach that you might choose would be based on a lot of different things. Remember, kind of that evidence-based practice triangle. Well, those are some of the considerations for choosing a treatment approach. Is there evidence for it in the literature? What do you know about the actual client and their particular disorder and what works best for them? And then your beliefs and perspectives as a clinician. These are all kind of the different sides of that EBP triangle. The research literature is one side. The perspectives and characteristics of the patient are another side, right? These 3 middle bullet points. And then clinician expertise and perspective as another side. Okay, so just to make this a little bit more confusing, right? You have certain goals for treatment just generally. When we're talking about what approaches we use, we're going to have some considerations. And then there's these things called therapy objectives, which really are very specific goals that we use to determine progress in therapy. And so we typically want to specify in these objective statements who is expected to do a particular behavior, what is that behavior, what is the condition under which that behavior is supposed to be performed, and what is the targeted degree of success. So it's important that objectives are measurable because that's how we document progress in treatment or therapy. So, but I think this kind of ABCD approach, or maybe you've heard of SMART goals, where you're very specific and you make measurable kind of criterion for the goal is useful for anything. So if I, for example, really want to work on making sure that I do the dishes, here is a use of this ABCD approach to make an objective for myself. Lisa will wash all of the dishes after dinner every weeknight. And so you can see A, that's me, the actor. The behavior is to wash the dishes. The degree is all of the dishes. And then when I'm going to do it, or the context or condition under which I will do it, is after dinner every weeknight. One of the goals that I might use in a session with somebody who has a voice problem, who we're working on better vocal technique with, would be Lila, as the actor, will use her clear voice, a particular type of vocal behavior technique across all verbal interactions across a 1-hour therapy session, which is the condition, and then 80% of the time. So I'm going to see if I can document that. And if she meets that, then.
All right. If you are kind of having a hard time making sense of this, or it's just kind of a lot of detail, I encourage you to create your own personal objective statement using this ABCD method because it'll make it really clear what it is. These are the ways that we kind of specify target behaviors, behavioral goals, so that we can document and take data on them. All right.
Then maybe I formulate a new goal, setting certain criteria that lead to discharge from therapy. Again, kind of going ahead and having some of these criteria are important for like third-party payers. So of course they help us with our treatment plan, but the reality is insurance also wants to see these goals and they want to see if the patient or client is making progress in relationship to those goals when they look at documentation. Okay, so the structure of treatment includes direct and incidental teaching. And so we have behavior modification as kind of like a cornerstone to a lot of what we do, particularly in speech language pathology, maybe more so than in audiology, right? So behavior modification is a systematic method of changing behavior. So if this SLP provides a stimulus, so maybe they indicate, all right, say your snake sound, and then the child, if we're working here with a child, they hopefully go, and then they've given some kind of reinforcement, maybe an M&M or praise of some kind. And that, again, is that process of behavior modification. Maybe they, instead of making their snake sound, make a sound. Okay, so maybe then they need some corrective feedback. No, bring your tongue up to your teeth and then push air through. Okay, so that sort of gives you an idea of behavior modification. It's very structured typically, and it's used to teach new behaviors of all different kinds. Incidental teaching is more like what we might see in a play therapy context. So maybe you're playing on the floor with a 2-year-old who appears to be language delayed. They don't have many words, and you are labeling things across the room and maybe playing with objects that are of interest to the child that you label and seeing if you can elicit the use of those same words by the child. Family involvement, particularly, of course, if we're working with kids, is so important for communication therapy and communication therapy success. We tend to give homework for speech and language therapies because that's how generalization happens. Practice. We want things to become automatic, but we also want them to be used, the new behaviors to be used in different communicative settings, and so carry over to those different settings and different contexts outside the therapy room often is going to take place with the facilitation of the family. We want to teach the family cueing strategies or strategies for communicating with the client outside the therapy room, which can be really important, again, for generalization and carryover. Okay, if you are at the end of therapy, typically you're going to determine that the individual has met his or her goals or the goals you formulated in the treatment plan. You're going to want to see that skills generalized to contexts outside of therapy. And after some time, you may want to check in with the family or have a follow-up assessment to ensure that the skills and behaviors have been retained by the client after the therapy has been over. Of course, if there is need to return, the family or the client should be encouraged to return if, it seems like there's some backsliding happening or regular follow-up might be scheduled in once formal treatment has ended. Okay.
All right, so that is our little glimpse into assessment and treatment, things that we'll refer to across the rest of the semester. Just a foundation for you, but wanted to give this to you now so you have it prior to next week. And then we will work on making sure that we, have some of these learning objectives in relationship to this lecture, one on the ear and the one on neuroanatomy, when we come back together next week. But until then, I look forward to seeing you in class on Wednesday and Friday when we will be having our wonderful guest lectures about neuro and the ear.